and thanks for inviting me here. I'm Simon Petrides. I'm an MSK in sports physician at the Blackberry Clinic. So what do we do when the patient understands all about their biomechanics and they've been to see Howard and they've had their neuromuscular control sorted and they've been to see an osteopath and a chiropractor and had their SI joints manipulated and adjusted without any success? Seen this picture before. I think John and I must exchange photos over the internet. That didn't sound right. So the SI joint can account for anything between 2 and 30%, or as a prevalence of patients with chronic low back pain, depending upon your population. So we'll talk today about guided injections using ultrasound, CT, or fluoroscopy, then diagnostic blocks. You can diagnose SI joint pain by numbing the SI joint or the ligaments, or excluding pain from the lumbar spine by medial branch blocks in the lumbar spine. Prolotherapy injections to stabilize the SI joint. Radiofrequency denervation, if you really have to, denervating the joint. And then a little bit about pubic symphysis treatment and interventions. And then one slide on regenerative therapies at the end. So anatomically guided, otherwise people call them blind injections, or clinically guided, using anatomic landmarks, can achieve about 22% accuracy. That's confirmed by CT scan. But we'll go on later to discover how CT scan itself doesn't necessarily let you know all of the information. But unguided injections can have their place, and it's worth learning how to do them if necessary. But if you use an ultrasound guidance, there's about a 40% accuracy depending upon the studies that you read. However, doing those injections, even if you do not get your substance, your corticosteroid, into the joint, there is no difference in effectiveness in patients who have sacroiliitis. And that was a study by Hartung in 2010. Now, another study in 2016 showed that fluoroscopy can achieve a 98% accuracy. I think that's a bit high. In my hands, it's less than that. But it does depend on, it's operator dependent. And again, if you don't get your contrast into the joint, there still seems to be similar outcomes with non-inflammatory SI pain or sacroiliac dysfunction. So with fluoroscopy, you can achieve an intra-articular sacroiliac joint steroid injection. We teach this at Blackberry education courses using the latex phantoms. We have other phantoms with real lumbar spines inside, which produce an adequate representation of the field when injecting the human body. There are various different approaches to the SI joint. You can inject the inferior articular recess. You can inject the inferior third or portion of the joint. You can attempt to get into the joint via the middle portion or mid-portion. There's a recent article in Pain Medicine Journal that's just described that particular approach. And you can also, I think a few months ago, there was another article in Pain Medicine describing an approach to the superior recess, higher up on, beg your pardon, yes, higher up on the SI joint here. So that all of the joint, there are ways to get into the SI joint, but the most commonly taught way in the Spine Intervention Society meetings is in the inferior portion. Now, CT-guided injections can be done. You would expect, looking at that needle, that the injection is inside the sacroiliac joint. But as I think it was one of John's slides earlier showed, that a lot of the sacroiliac joint includes the interosseous ligament. And so you actually need to evaluate it against contrast injection. So in the CT-guided injection, the accuracy perhaps is only around about 50% in getting into the SI joint. It's also a less accessible image modality and more expensive. So actually, most people perhaps in the audience here, in their MSK SEM clinics, will actually see patients whose pain actually comes from the ligament structures in the SI joint. And the previous speakers have mentioned Kuzi's study on SPECT scans, which alluded to that fact. So periarticular injection, intraligamentous injection, would appear to be a valid option. And John mentioned Murakami's trial of 25 patients, where he injected local anesthetic into the ligaments and achieved numbing of the patient's pain in 100% of patients. Injecting into the joint, he only achieved numbing of the pain in 36% of patients. And these were patients who all had their pain provocation tests positive in at least 3 tests. So with sacroiliac steroid injection, there is evidence for effectiveness in maybe 66% of patients in one study in 2009, and that could last around 36 weeks. And that, however, is only in patients who have had the sacroiliac joint diagnosed by dual comparative blocks. Now that's injecting lidocaine on one day into the joint, giving the patient a pain diary, going away, patient comes back, they got pain relief for an hour. Get them next week, giving them an injection of bupivacaine, marcaine, into the joint, and they go away with their diary, come back, and they got pain relief for 3 hours, or thereabouts. And that is a positive dual comparative block. That has the highest chance of being a sacroiliac joint pain. You then inject corticosteroid intra-articularly, assuming the joint is the pain generator. And in those cases, there's a 66% effectiveness. Right, the nerve supply, again, has been talked about a little. The nerve supply that we are interested in is to the posterior sacroiliac ligaments, and that comes from the lateral branches of the posterior primary rami of the sacral nerves, or the dorsal rami of the sacral nerves. And it's primarily S1 to S3. Sometimes S4 is included, sometimes the dorsal ramus of L5. Dorsal ramus of L5 is up the top here, and S4. So there is a variable supply, but from S1 to 3 it's quite consistent. And the front anterior part of the joint is supplied by the lumbosacral plexus. So in more detail, we've got what's called the posterior sacral network, which is those sensory nerves. Now you will see on the left side, S1 to S3, there's a remarkably consistent location of those the sensory nerves. And in 25 cadaveric specimens, these were dissected in 2014, they showed that 92% of them were actually in the locations that I've specified. So if you see here, S1, 6 o'clock and 7:30, the nerves are actually 1.2 centimeters away from the posterior foramen of S1 at 6 o'clock and 7:30, and the mirror image on the other side. S2, 6:30, 8 o'clock and 9:30, S3, 9:30 and 11 o'clock. Again, mirror image on the other side. So actually, 92% of the time, if you inject those places with local anesthetic, you're going to numb that joint. It also crosses the sacral network, crosses the lateral sacral crest, which is here. And that's between the first and the third transverse sacral tubercles. And that's where, when people are injecting using this technique of lateral branch blocks, using ultrasound, they look for that lateral sacral crest. So using anesthetic injections with a lateral branch blocks, you can do multi-depth, multi-site local anesthetic injections, normally with 0.5% marcaine. And this was described by Dreyfus in 2009. And that will anesthetize the posterior sacroiliac ligaments, the interosseous ligaments, the short posterior ligaments, and the posterior part of the sacroiliac joint capsule. And since most of the pains that we all see come from those ligaments, it's actually quite a useful bit of information. If that technique numbs their pain for the first few hours, or you've also excluded it by doing medial branch blocks for the lumbar facet joints. You've excluded lumbar spine pain. So you've got even more information. It's not coming from the lumbar spine facet joints. It seems to be coming from the sacroiliac ligaments. So we're getting closer to the diagnosis. You can, if you want to, and you think there is an element coming from the actual joint itself, anesthetize the sacroiliac joint with an intra-articular dual comparative block. We tend to just do one block because getting the patient to come back 2 or 3 times is not very effective or cost effective, and it's not easy to continue in that way. So just doing a single local anesthetic block into the joint, it often gives you enough information along with your pain provocation tests, your evidence on the history that the other speakers have spoken about. So that is supposedly the gold standard of diagnosing intra-articular sacroiliac joint pain, such as sacroiliitis or degenerative change. So if we've established that the pain may well be coming from the sacroiliac ligaments, and it is mediated through those lateral branches, through the sensory nerves, and maybe the patient has not responded to a steroid injection, or perhaps has not responded to prolotherapy, you can denervate the joint. Radiofrequency ablation, radiofrequency neurotomy, neurolysis, denervation, they all mean the same thing. And the idea is to promote axon protein degeneration within the axon, denaturing the protein, Wallerian degeneration distal to the lesion so that there's no sensory input from the joint. You can use probes, different types of probes here, the standard probe, the cooled probe, bipolar. I've even heard of endoscopic, and then ultrasound or fluoroscopy guided. And these are producing an electromagnetic field through the tip. I don't think you can see on here, but there is an exposed tip of perhaps 0.5 to 1 centimeter long, and that will affect any structures within a few millimeters of that tip. And in the right hands, after dual comparative blocks, that technique has been shown to be effective in 60% of patients up to 9 months in duration. So there's a typical neurotherm lesion generator, which can be used for generating radiofrequency lesions in, say, medial branches of the lumbar spine, the cervical spine, or the lateral branches of the sacroiliac joint. And here are some electrodes placed perhaps a little bit close to the posterior foramen on that side, but that's just an example of what we're trying to achieve. You have to find the posterior foramen first, and then position your electrodes, and then turn the machine on for 1.5 minutes. And it doesn't allow the temperature of the tissues to rise any more than 80 degrees C. We don't want boiling tissues. So another option of what you can do for these refractory SI joint pains is prolotherapy. Different concentrations of dextrose can be used, from 5% to 25%. One of them, P2G, one of the mixtures, has a 12.5% solution of dextrose and 1% of phenol. And the mechanism of prolotherapy, for those of you who don't know, is either hyperosmotic irritant effect to the collagen cells, or a chemical irritant of the phenol from P2G. As a result, you get an inflammatory response. In 5% dextrose, there is more recently been described a neuromodulatory response, where you get downregulations of TRPV1 receptors and ion channels in the sensory nerves. So the result being an increase in cytokines. You get fibroblast deposition. Fibroblasts here, but that's before prolotherapy, and that's afterwards in a ligament. You get fibroblast deposition, thickening and strengthening of the collagen fibers. And as I said, there's a neuromodulatory effect as a possible secondary effect. So you get less sensitivity of the tissues. So Cusi, who was busy in this field in 2010, found a cohort of patients with sacroiliac joint pain provocation test positive SI joint pain. Then he used a CT-guided injection to inject the posterior ligaments with hypertonic dextrose and demonstrated a significant improvement up to 2 years. Now, another study by Kim in 2010, he injected 5% dextrose into the sacroiliac joint and demonstrated a better pain relief over 6 and 15 months, up to 6 and 15 months, against steroid injection. Now, prolotherapy traditionally is done to several sites around the sacroiliac joint: the iliolumbar ligament, the short and long posterior sacroiliac ligaments, the dorsal SI ligaments, the interosseous ligaments. And those 4 sites, A, B, C, and D, were described by Hackett, and they're taught as the Hackett sites for injection of the SI joint. They don't, in America, use image guidance. In most cases, they don't use image guidance, so they use a lot more injections. We tend to direct our prolotherapy under fluoroscopic guidance, so we probably inject less solution in more targeted places. You can also inject sacrotuberous and sacrospinous insertions on the lateral border of the sacrum. Right, moving on to the pubic symphysis. Pubic instability and pubic overload seems to be the underlying pathology regarding a lot of these pubic conditions. Osteitis pubis is one of the common ones that the athletes see. Other names of pubalgia, pelvic instability, these are quite random names, some of these. Groin disruption injury, conjoint tendons tears, sportsman's hernias, these are all evidence of pubic instability. And then something I've seen quite a lot of recently is pelvic girdle pain, symphysis pubis dysfunction. After 1 or 2 babies have been born, the ladies find their pelvis is just not working properly, with pubic pain at the front and sacroiliac joint pain at the back. Again, another name for that is postpartum pelvic pain. So the pubic symphysis has quite a strong superior ligament and an arcuate ligament at the bottom. They're both very strong. There's a partial capsule. There's also a fibrocartilaginous disc, and that's an MRI image of the same thing. The aponeurotic connections of the pubic symphysis are quite complex, but they all converge. All these abdominal and pelvic stabilizer tendons and aponeurosis converge on the pubic plate in superficial and deep layers. And they provide a kind of hub for all this force transmission between the abdomen, the pelvis, and the hips. And these aponeurotic tissues, they blend with the capsule of the pubic symphysis and with the disc. So you can see external obliques here actually crossing and joining the adductor longus aponeuroses as well. So they're linking the stabilizers, as was described by Howard. They're all converging on that one point. The deeper plate, otherwise known as the modiolus, emphasizes how much more, many more tissues are also involved in that force transmission, namely pyramidalis and the conjoint tendon, the inguinal ligament, adductor longus and gracilis, adductor brevis, all converge on the pubic symphysis, and you can imagine why that suffers, especially in contact sports or sports that involve change of direction and sprinting and kicking. So you can inject the pubic symphysis if the physios in various teams are struggling with rehabilitation. That's a fluoroscopy needle, just end on, being injected into the pubic symphysis, and then the little blue spots are areas that we usually use in prolotherapy when you have a temporary or incomplete response to steroid injection. So several different sites into the connective tissue around the pubic plate. And of course, if you want to stabilize the pubic symphysis, you sometimes have to stabilize the SI joints as well if they're getting symptoms from that. So alternative injections that are on the horizon, apart from prolotherapy, there was a review of 18 studies in the American Sports Medicine Journal this year, a systematic review that came to the conclusion that platelet-rich plasma does work, but it seems that it might work better if it's leukocyte-rich. And that was the conclusion of that meta-analysis. Stem cells have been injected around ligaments, around the lumbar spine, bone marrow concentrate, amniotic tissue, and alpha-2 macroglobulin, which is a matrix metalloproteinase inhibitor. And I've even heard of a patient who's had tetracycline injected into their sacroiliac joints because it apparently is a matrix metalloproteinase inhibitor. But these are all on the horizon, and we're waiting for more evidence. Thank you.